Good afternoon. My name is Guy Mansetto, representing the PCPCC, and I would like to welcome everyone to our executive webcast. Today's executive roundtable is entitled Population Health Management within the Patient-Centered Medical Neighborhood, recently published by the PCPCC and is fully available from their website. Today's discussion will be centered around this paper. Sorry about that. Today's discussion will be centered around this paper, which introduces healthcare IT components and technologies required to perform population health within a patient-centered medical neighborhood. All lines have been placed on mute to prevent any background noise. Today's presentation and discussion will last approximately 1 hour, and there will be time available at the end for Q&A using the electronic question area in the bottom portion of the GoToWebinar controls. During the presentation, we will have several sections where you can also submit questions that are relevant and timely based on the topics discussed. And again, feel free to use the question area in the GoToWebinar controls to submit your questions, and we will do our best to review those as we go along. I'm delighted to be here today with several of the contributors and healthcare organizations involved in this particular publication, including Dr. Jaan Sidorov, Principal of Sidorov Health Solutions, who's not only a general internal medicine physician with over 20 years of experience in primary care, disease management, and population health care coordination, but also one of the reviewers of the publication. Also, Robert Fortini, Chief Quality Clinical Officer of Secours Medical Group, also noted in the publication within the case study section and also involved in the publication. And Dr. Richard Hodak, Chief Medical Officer of FITEL, a leading population health management technology organization, and someone very, very familiar with population health as it relates to the patient-centered medical neighborhood and medical home. So why is population health becoming more and more critical in healthcare? And it goes without saying that there has been a tremendous amount of increase in costs of expenditures for healthcare that have outpaced general GDP and wages. And if you look at kind of where the waste in healthcare exists, a lot of it is around care coordination, care delivery, resolving care gaps, in addressing engaging patients, which leads us to today's topic of using population health technologies or strategies within the patient-centered medical neighborhood to ultimately improve quality for patients and reduce costs. If you look at the technologies or the 10 recommended healthcare IT technologies listed in the publication, you can break it down into several different areas. One is within the practice having electronic medical record and the clinical decision support required, along with a patient-centered registry to capture patient information and to be able to provide analytics on top of that information to make better decisions. In addition, you need tools to risk stratify that data. And that data might be from one EMR or multiple EMRs. It might be from other clinical systems or other patient-entered data, but also claims data, providing cost claims information to the predictive models to make, again, better decisions in terms of who to engage and which patients need to be cared for along the care continuum. Third, patient engagement, using technology to engage patients in ways through automated outreach, through providing patient portals where they can get access to their health data, but also communicate with the care team. And track other information that's taking place within the healthcare medical neighborhood, including specialty care, hospital-based care, post-acute, and other care centers, to capture where those care transitions are taking place, and again, to engage patients at the right time based on the right setting. And lastly, there are a number of technologies listed in the guide that relate to remote monitoring. Not only who is available who actually you see during the course of the day from a patient visit standpoint, but which patients can you remotely keep track of and help keep active and engaged in a very patient-centered way within care practice. So the 6 topics of today's discussion really are going to be in these areas. One is the cultural movement or aspects of population health management, scaling and automating much of the required function of performing population health management within a patient-centered medical neighborhood, monitoring transitions of care across the medical neighborhood, engaging patients, monitoring and acting on patient entered data or remote biometric data or remote information, and again using advanced population analytics to best risk stratify populations and identify patients most in need of care. These 6 areas are going to be discussed in 10-minute blocks. We have about an hour to spend on these 6 areas. And I will be asking the panelists a series of questions related to these 6 areas. And we'll also open it up for some dialogue and some questions that you all can submit electronically. So if you see an area that is of interest to you, please keep that in mind. Jot down your questions and your notes as you go along. And we'll try to accommodate as many of the questions as we can get to. So the first area is around cultural aspects of population health management. I had the pleasure to hear Dr. Farzad Machari speak at the CHIME event last month. And in that event, he indicated that he was hopeful and optimistic. And in terms of having new technologies and systems, he was a little concerned in the fact that many healthcare providers and care teams really need more education in terms of how best to do this. Meaning the technology is there, but healthcare organizations can buy population management software and technology, but flipping a practice, as he said, or flipping a hospital so that everything doesn't take place within an 8-minute visit or a 6-minute visit is really a cultural challenge, not an IT challenge. It's a business process or business practice challenge. And as he indicated, with all the pace of change that's occurring, frontline providers are being asked to do more and more of them, and care teams are being asked to do more of them as well. So with regard to the cultural changes or the cultural aspects of population health management, my first question really goes to the panelists is what types of business process and cultural changes enable this successful transition towards the population health management model within a medical neighborhood?
Good question. This is Jaan Sidorov, so I'll jump in and pipe up. You know, a lot of systems have to decide ultimately between buying or building, and I bring that up not so much to speak on behalf of the vendors who have a stake in this, but I bring it up from an internal organizational dynamic, and that is in a network of primary care, frontline providers, family practice, endocrinologists, other persons seeing patients in the medical neighborhood. There has to be a decision within the organization. I believe this is a cultural one between expecting the individual clinics, the individual work units, to assume the cost and responsibility of implementing all those components of a patient-centered medical home, and that includes care managers, non-physician care managers, versus a central hub that assumes ownership for this and distributes these individuals out to the network. I'm amazed at how often organizations expect individual work units to assume the cost of hiring an additional nurse, for example, to do care management, when in fact there may be greater efficiencies in doing this internally, but that is a Rubicon that is cultural in my mind that needs to be considered when you're thinking about these primary care sites tackling thousands of patients that all of a sudden the organization is accountable for.
Great, thank you. Robert, do you have any thoughts on that? Seems like we might have
lost Robert.
Dr. Hodak?
Yeah, let me go ahead and just say something on it. I think that I agree with Dr. Mastrari that it's going to be difficult, but I am seeing a lot of change. When we look at the clients that we're working with, I'd say probably 80% of them are starting to think about cultural change, how to build or plan out the patient-centered medical home, and they're starting to look at the accountable care organization. Despite the fact that they're talking about population health management, doesn't necessarily mean that everybody is well educated, and I think there is going to be, a need for education. I definitely think there's going to be a need for clinical leadership. Somebody's going to have to be within the organization locally that gets education in population health management and is able to lead the group forward. And there's a big need to change the workflow that exists, currently in the office, and that may take policies and procedures, to actually define roles and responsibilities and show processes. And I think Lean Six Sigma is something that's going to be, very, very helpful in that regard.
Great, thank you. A number of questions on the same topic rely on really the academic area around medical schools and what you all are seeing in terms of the curriculum of medical schools adapting towards team-based care, patient-centered care, population-based management models. How are you seeing the educational arm of this evolve, where care teams and providers and clinicians are really looking at ways to think differently around this cultural aspect?
I'm heartened by movement within the academic community to recognize that it's no longer that the purpose of medical education is to no longer train students to become individual clinician scientists who use what I call a hero approach, an individualistic hero approach to deciding on each patient the merits of treatment protocols that they have personally vetted in their own personal review of the scientific medical literature. There's far more interest in getting students to be enculturated into teaming, working in a mutually transformational, interdependent fashion for the betterment of patient care. That being said, I also, in my walks through with policymakers as well as politicians, am detecting an increasing level of impatience with the academic community and its ability to turn out, if you will, enough primary care clinicians to the point where it's becoming increasingly difficult, I think, for a lot of us, especially as primary care providers. I mean, if there's a certain, let me put it this way, if there's a certain percentage that I, as a physician, of my diabetics that need to have a target hemoglobin A1C, and we can debate that, but let's say it is 7%, why not hold accountable our academic colleagues to the same level of accountability and ask them to reach a certain target threshold of a certain number of primary care clinicians who are out there in the front lines, meeting our nation's healthcare needs. That's an interesting question and an interesting debate that goes far beyond the confines of this webinar, but I do bring that up.
Excellent, Dr. Sidorov. I appreciate the commentary. The other question in this area has to do with the roles really required within the medical home, the medical neighborhood, to really support population health management. Do we still have Robert Fortini out there?
Guy, I'm here. Can you hear me now?
can. Very good. Can you talk a little bit about the roles that you're seeing within Bon Secours helping support Population Health?
I would love to. Let me just back up and comment. Dr. Sidorov, I couldn't agree with you more. You know, changing the curriculum at our academic institutions into a more of a teamwork approach rather than that individualistic hero. What is it? Tul Gawande says, pit crew versus cowboys, right?
Yeah, exactly.
You know, absolutely a necessity to teach the value of a team approach. In the medical home model, in my experience, that's been the most difficult aspect of implementation is to getting those fiercely independent practitioners to all of a sudden understand how to use the tools that they're being given. You know, a registered dietitian that's embedded, or a nurse navigator for case management, or a pharmacist, and hand off. You know, actually hand off the work to them. And inevitably, it takes a good while. And, you know, it ranges depending on the individual practitioner. Those who have been in practice in internal medicine, for example, for 10 or 20 years, it takes a little bit longer than your new grad family practitioner. But inevitably, it takes a bit of time to do. So, I just mentioned quickly a couple of the roles. What Bon Secours has right now 68 nurse navigators. These are both RN case managers and LPN panel managers. So I think, Dr. Sidorov, I've heard you speak about, using skills up to the fullest level of licensure is a great place to start with this. But if we acknowledge that in Western medicine, medication adherence is a huge part of medical management. I think 25% of all hospital readmissions are because of some kind of medication adherence problem. Then the role of pharmacy becomes altogether more important. So again, in our medical home model, working side by side with physicians and nurse navigators, we have PharmDs that see patients on a regular basis. And for the more complex patients with behavioral health issues, we have licensed certified social workers. Chronic disease and behavioral health are joined at the hip, and you can't manage it just with medication. You got to treat the depression and the mental health issues that go along with it. So that's just a brief kind of review of the different types of practitioners that have to be on that pit crew. So.
Fantastic, Robert. Appreciate it. Dr. Hodak, do you have any additional comments?
I just wanted to say, because it's an important part of my life, is I think that part of this team, which it needs to be put together, a high-performance team, should be technology, because they're just our pieces of this overall care of a population that technology can help with. Certain automated forms of technology can help so that you can be more efficient and effective.
Okay. Excellent. Okay, we're going to move on to our second area of discussion, which has to do with scale and automation. Just to level set, the Care Continuum Alliance defined the Population Health Improvement Model as a model featuring a physician-guided healthcare delivery system designed to develop and engage informed and activated patients over time to address both illness and long-term care. The ability to achieve the goals of population health management, however, only becomes possible, as was indicated within the publication, when health IT technology applications underpin and drive fundamental activities of practices, providers, and care teams and the like. With data supplied by registries, enterprise data warehouses, analytic software that can be used to help stratify population by health risk, identify care gaps, and set priorities for care planning, automation tools are increasingly becoming important to help facilitate care management, patient outreach, distributing health risk assessments, web-based education, and the like. As organizations are increasingly looking for ways to scale care management workflows within a health system or a practice, scaling and automation really is the next topic that I'd like to spend about 10 minutes on. Which of the health IT elements described in the paper do you feel one or more can really have the most dramatic difference on the health outcomes of a population? Dr. Sidorov?
I'm personally, they're all interdependent, all synergistic, and the more you use all of the elements described in that excellent monograph, I think the more mutually supportive they become. That being said, I personally believe that predictive modeling, risk stratification, using inputs such as insurance claims, information from the electronic health record, health risk assessments, can be used in increasingly within reach mathematical modeling, logistic regression equations that persons with master's degrees and desktop computers can do. But there's some very good products out there that can be bought off the shelf with all kinds of support from teams of PhDs. I'll let other speakers talk about that. But the ability to have a population understand what the risk is of certain individuals and to prioritize and target those individuals, not only persons who are at high risk, but modifiable risk. It's one thing to identify patients who are at risk for readmission. It's another thing to be able to identify patients at risk for readmission who can be headed off at the pass by the additional mathematical and analytics to identify which patients have modifiable risk, and then pairing that up with the right kind of care management interventions. I believe that's probably the thing that impresses me the most in the last 1 to 2 years.
Great, thank you, Dr. Sidorov. Robert, do you have any comments on that?
Sure. And again, the technology is out there. There's no question about it. And predictive analytics is an extremely valuable tool. If you think of this strategically like a military campaign, you use that wide-scale automated surveillance as your radar screen to just find the population. And then you use different types of alerts and triggers to identify the narrower subset of the population that has that modifiable risk. And then you use the first face-to-face personal interaction to do case management on the most at risk. And all of the technology that's available to do that, and most of it is existing today. Some of it is learned. Some of it, you can use something as simple as a LACE scoring index or a Charlson comorbidity scale, and you learn it. Once you're looking at a patient and you realize that they have a 50% mortality rate in the next 12 months because of this score or these lab values or these vital signs and comorbidities, all of a sudden you approach that patient a lot differently as a practitioner, as a nurse, or as a social worker or a pharmacist. It makes it real. So, I agree. The automated the technology that we have is extremely valuable, but the ability to, learn the comorbidity, learn the mortality rate just from experience is invaluable as well.
Great. Thank you very much, Dr. Hodak.
I think slightly different, point of view. I think all of these things are important, but outside of the EMR, the next important thing is probably the patient registry, and the patient registry is not, necessarily something that's for every different condition or every different preventive modality that needs to be addressed, but a patient-centered registry where all the data revolves around a patient. And when you look at this patient in the registry, you can see whether they have preventive needs, whether they have a condition that needs, things taken care of, whether they have multiple conditions. So a patient-centered registry is important. Once you have that, then you can start creating the right reports and taking action by writing rules against the registry. So I think the registry is a very important piece of these 10 different IT pieces.
Okay, great. Thank you very much. Well, we're going to go ahead and move on to our next topic, which is around transitions of care. So only about, the paper indicated only about 17 to 20% of primary care physicians report that they're routinely notified of discharges. 20 to 40% say they've received discharge summaries 2 weeks or more after their patient leaves the hospital. HITs can help, but the study indicated that only about 30% of the hospitals and 10% of ambulatory care practices participate in such HIEs, which will increase over time with meaningful use and a number of the other regulations. One lever is the regulations around meaningful use, stage 2 and stage 3 and beyond, requiring providers to exchange care summaries at transitions of care such as hospital discharges and specialty referrals. But that exchange must take place electronically in only about 10% of such transitions, and just once with a receiving provider who uses a different kind of EMR or HR than the sender. Putting aside whether or not an HIE is in place, which adds a layer of complexity in terms of the technology used, what simple IT strategies or approaches can be used to better transition care and improve coordination between acute care and post-acute care facilities? Dr. Sidorov?
You know, in my travels, I've become increasingly impressed with the interest of the commercial insurers outside the standard fee-for-service Medicare and fee-for-service Medicaid, but even fee-for-service Medicaid. This isn't necessarily true depending on which state you're in, but the hunger of the commercial insurers to be routinely notified when their patient gets discharged from the hospital is amazing. And that's because the Aetnas, the Cignas, the United Healths, the Blues of this world have all invested heavily in their own care management programs that are insurance-based, but which are very vulnerable to notification by the inpatient facility or the skilled nursing facility in letting them know when a patient is on the way home in a home-based transition of care. They oftentimes have resources that can help coordinate many of the community-based services, as well as increasingly robust, I think, connections within their primary care network to let physicians know when that's happening. So I'd say of all the things that you could do, and there are a lot of things that need to be done when it comes to transitions of care, automating the alert of a patient's current insurer that the patient is making a transition of care would be the top of my list. Great.
Robert Fortini, do you have any comments in terms of what Secours is actively involved with?
Oh, sure. As you know, we're an Epic shop, 7 hospitals, so we see all our discharges from our own facilities. The challenge then becomes, you know, out of network and understanding. And Dr. Sidorov, to your point, you know, we've entered into several ACO-like contracts with our largest payers. Anthem and Cigna in particular have led the way with that, and we get real-time notification of admissions, not discharges, admissions, on a daily report. So a very valuable information because, you know, many times we could even visit the patient before they leave the hospital. But more importantly, I mean, when they're in our own facilities, being able to follow up on them after discharge from facilities that are not owned and operated by Secours is of tremendous value. And yes, you're right. There has been a real appetite for pushing that information into the hands of the practices that can do something with it. Like I said, we get a daily admission report from both of those companies, and are in negotiation with at least 3 more to do something similar.
Okay, excellent. A lot of talk has been around risk stratification during our roundtable today. How effective do you see predictive risk models and stratification at identifying risk, whether it's unnecessary readmissions or high near-term costs or high expected costs? How do you see these models evolving to be more effective with both specificity and accuracy? This one we'll start with Dr. Hodak.
Yeah, thanks, Guy. claims-based risk models are certainly able to identify individuals for future admissions. But there could be some problems in the fact that the claims-based models have some delay in data. I think if you could get data right from the hospital discharge data, the EMR data, combine it with patient-reported data and take action on these people within 24, 48 hours, that's going to be a better way in which to prevent the admission. You can identify people with comorbidities, people who are having trouble with multiple medications, people who don't understand the care plan very early in the course of this transition, and try to get them into a physician or into a care manager.
Excellent. Okay. Dr. Sidorov?
You know, when I was helping to train residents, one of the things I pointed out to them is that standard medical tests that a lot of us take for granted, EKGs, chest x-rays, are like teenagers. They lie sometimes. And for anyone who's a parent listening on this phone call, you understand what I'm talking about. And it turns out that those standard tests, blood tests, can have a false positive and false negative rate anywhere up to 30%, and some tests that are routinely used in medical settings are in that same range, a 30% lie rate. Physicians, I think, are very, very critical of these lists of patients that predictive modeling and HIT can produce of patients who are at risk, patients who normally are assigned to a physician, or patients who have been discharged from a hospital. And my message to my fellow clinicians is that we are tolerant. We've learned to figure out how to include the lie rate in many of the blood tests that we use in day-to-day clinical practice. The same thing's true when it comes to population health. There's a certain level of inaccuracy. It's getting better in predictive modeling and identifying patients at risk, but that doesn't mean that we can't use those tests for patient advantage. The models are getting better as the inputs increase, especially from the electronic record. You know, I think the sensitivity and specificity is going to be in the range of 80 to 85% with good predictive accuracy.
Excellent. That's excellent. Robert, do you have any other comments on this topic? I think you know, one of the things that we're seeing is that the models seem to be more and more prevalent in the industry in terms of trying to identify predictive risk, but also kind of what tools care managers are really leveraging to help identify those risks and how to best incorporate it into practice. We're seeing a lot of hospitals, for example, combine the case management function, traditional case management function, with the care management function. How do you see these tools evolving and aligning with ambulatory care?
Well, back to my point earlier about using simple tools. I mean, using them more effectively and completely, and starting on admission to understand that this patient in the front of you is, you know, got a 50% mortality rate in the next 12 months, or is very likely for a readmission, heart failure, pneumonia, AMR, COPD to start. We have started that. We're using a predictive modeling tool in the platform, and those patients that hit the radar screen at the top 10% get very careful handoffs to the ambulatory side. A lot of hand-holding, a lot of message taking, a lot of communication within the record. And so, yes, you're right. They are becoming more sensitive, and as we get better at documenting and understanding how they work, the accuracy is improving. The handling, you know, that transition of care from inpatient to outpatient, you know, it's a lot of attention has to be focused on that for the at-risk population.
Okay, excellent. Well, we're going to move on to our final batch of 3 sections of questions, or 3 areas of questions, one around patient engagement, one around remote monitoring, and one around claims analytics before we open up for general questions. But around population engagement, or patient engagement, the population health management model, as indicated in the research paper, requires an organization to really identify and reach out and engage patients who have care gaps and engage them to get reacquainted and reactivated with their care team and provider, or take other actions to help close these care gaps. And we feel that in some respects automation is critical to help automate and systematize this approach. How does automated messaging and outreach achieve kind of the standard of care for a medical home? I guess this kind of goes right back to Robert, and then we'll go right to Dr. Hodak.
So I'm a little confused here, Guy. I'm sorry. You're talking about automated messaging to patients?
That's right. Automated messaging and outreach. What's been your experience within Secours around automated communications?
So it's been very good, and we have a number of different modalities that we've deployed. And certainly, the one is a good starting point is the patient portal. Like, for example, with the onset of flu season, we've messaged all of our patients who are have open accounts, come in and get your flu shots. Our flu shot vaccine rate has been very high this year. Whether it's because of that or not remains to be seen, but it was an effective method of communication. The other thing that we have used successfully for several years is interactive voice recognition technology. And we use it to manage chronic disease as well as preventative disease categories. The sheer volume of phone calls that automated approach can make would not be, we would not be capable of delivering that if it was human-based technology and outreach. I've seen some different comments about whether or not it's valuable, but I'm looking at the ROI as a businessman as well as a clinician, and I see the definitive ROI there. Even if we're only successful 30% of the time, that's still 3 out of every 10 people that we're touching. And even if we only get them in for a visit 1 out of every 10 times, that's still, when you're doing 400,000 phone calls a year, that's still 40,000 patients that you're arriving to visit. And those patients are an at-risk population. We've deployed 20 different chronic disease protocols, and I think 18 different preventative category protocols. So we've used that technology very successfully at Secours.
Great. Comments, Dr. Howard?
And from my point of view, I wanted to, re-emphasize that with the high-performance team, I said that there was a good reason to have technology in there as one of the team members, and this automated messaging is just one of the areas where this can happen. It's not unusual for a health system to have 100,000 patients, and when you look at the paper, the RAND report, 40–50% of those patients don't have care gaps. It's a lot of people that you need to reach out to. So being able to identify the people that have gaps in care, following evidence-based guidelines, and connecting with them by a method that they enjoy, either phone, email, text, or paper, and if it gets to them at the right time of the day with the right message, that can be very powerful in moving the needle on these gaps in care.
Excellent. Health risk assessments are another really important data point for population health. And Dr. Sidorov, I know you're very, very versed in the effectiveness of those tools. How best can care teams within a medical home or medical neighborhood leverage that data, the health risk data, within the way they engage with patients?
As a clinician who's been on the receiving end of health risk assessments as well as other tests, I can tell you that many primary care clinicians, including myself, the initial reaction is skepticism over basically a bunch of information and a bunch of tests that was never really ordered by the primary care physician. Now, that speaks to the cultural issues that we spoke to before. But I've generally found that under these kinds of circumstances, the results from a health risk assessment are best handled by the care management side of the medical home team within the functioning neighborhood that's responsible for the care of a population. The other thing is that it's not while the role of an HRA is to point out that a certain person hasn't had a mammogram and that a certain person with a prior history of myocardial infarction hasn't had a cholesterol level within the last year, the more important role of an HRA, I think, is to roll up all those individual data points into a global assessment of risk, so that the persons taking the HRA are arrayed in their risk from high to low, both not only on the basis of risk, but what I mentioned before, impactable risk, so that we know that Jaan Sidorov at the age of 58, of all the thousands of patients that were surveyed with the HRA, has the highest risk, and that is at the top of the list for the care management personnel to call to find out what's going on, and then use those, and then go into the individual questions and see what risk factors can be modified. That's generally the state of the art, in my mind, how it's done.
Excellent. Well, the next question actually has to do with distance monitoring. And Robert, I know Secours has been very innovative in ways to engage with high-risk patients remotely and through technology. Do you want to describe a little bit about what you all are doing and the effectiveness?
I'd be happy to. There's all degrees of relativity here. We've just finished a heart failure initiative where we did what I referred to earlier, identifying at-risk for readmission heart failure patients, highest risk, in the hospital, and then transitioning them to a home health visit as an extended agent of the hospital. What we found is that we're sending heart failure patients home on diuretics, and they don't have scales in their houses to weigh themselves, so that they cannot see the impending regression until they're short of breath and dialing 911. So, telemonitoring and distance monitoring is very relative here. We are using some state-of-the-art equipment, however. We have a 3G-enabled technology that does 24/7 EKG monitoring. The device deploys skin temperature monitoring as well as an accelerometer and a diagnostic grade, EKG. Combine that with a pulse oximeter, a blood pressure cuff, and a weight, and you could do an awful lot of monitoring from 100 miles away, including orthostatic blood pressures. The problem is that it's so much information that we can't overwhelm our physicians, cardiologists, endocrinologists, primary care physicians with that amount of data. So we needed some kind of filter on it, and that usually means a non-physician team member who is monitoring a dashboard of patients and has a red, yellow, green indicator when various thresholds are hit in different categories. And those thresholds can be set by the clinician, but they're only alerted at the very end when the threshold is exceeded. So we have a pretty big pilot underway at the moment. It's turning out to be extremely successful. We've had a very low readmission rate with this type of concierge monitoring from afar. And I'm confident that within the next several months that we're going to be rolling it out across the Commonwealth of Virginia.
Very, very interesting. One of the aspects or one of the areas obviously is payment. How is it ultimately a fee-for-service model going to support remote technologies? And as time goes on, we're seeing more and more value-based care arrangements, accountable care arrangements, where shared savings really is the goal, and reducing total cost, improving quality really is the goal. How do you see payment models, Dr. Hodak, kind of evolving from where they are to really manage remotely patients in the new environment?
I have a feeling that in the very near future that type of remote monitoring is going to be a very fee-for-service billable procedure because the return on investment is dramatic. So yes, you're right. Right now, we are in the Medicare Shared Savings Program, so we're looking to share in the savings of a readmission. If you look at the average spend on a readmission rate, it's just under $10,000. And so in a heart failure patient who's 6 times a year in a hospital, if we could prevent 3 of those, we're you know, $30,000 ahead, right there. When you add 30-day readmission penalties, there's significant downside risk reduction as a benefit as well. So, you know, right now that's our payment model, but again, I see the handwriting on the wall for it becoming fee-for-service as well.
Excellent. Dr. Hodek?
Only that I agree with him that there is a business case here that's pretty clear. High risk drives high utilization costs, and this technology can show improvements in care, keep these people from being readmitted, and ultimately will decrease the total cost of care, making it a very favorable thing, fee-for-service as well as the value-based models that are out there right now.
Excellent, and that kind of leads us to the I guess the final topic or the final section of the roundtable. And again, I appreciate the experts expertise on the call. We have predominant domain experts of population health and utilizers of population health technologies within the field on the call today. So I appreciate everyone's time joining our session. And our last section has to do with claims-based analytics. And the reason why I think the claims-based analytics is important in a practice setting is claims does provide really that total cost of care, really what occurs with that patient outside of network or outside of particularly in-office visits or outside of what might be known to care teams at any given point in time. There's been some question or some concern about claims data being less actionable than clinical data because of the lag time and really the completeness of the claims data and accuracy of the claims data compared to the EMR record. But this kind of brings up a whole topic around population health, around claims data, which is really what's the best way or what are the best strategies to use clinical cost data effectively within the current care team workflows. And I'll pass this to Dr. Sidorov, who hopefully can provide some insight.
Yeah, you know, the problem with insurance claims, obviously, is that by the time the provider gets around rolling them up, packaging them, and submitting them to the insurer, and the insurer receives them, adjudicates them, and pays them, months can elapse between the time that the patient actually incurs the claim and the claim becomes usable in an IT environment. I think insurers are getting better at cranking those claims through the system and coming up with a better, faster, and more nimble set of analytics. Unfortunately, I think that puts the providers who are at risk, especially whether it's downside or upside or global capitation or global payment arrangement, that puts those providers at risk. I think what we're going to see is that organizations are going to become far more nimble at rolling up their own claims before they're even submitted or as part of the submission process to provide the same kind of in-house analytics to their claims, attached to the same diagnosis codes, attached to the same modifiers, and attached to the same demographics, plus additional information that can be dredged up from the electronic health record to come up with a set of predictive variables that are far more accurate and far more specific to the local organization. I think that's going to become increasingly true for these larger organizations that have hundreds of thousands of members in it, but I think we're going to see it increasingly being used for the smaller organizations that are responsible for, you know, as few as 100,000. I'd be interested in hearing what the other speakers have to say about that.
Well, I think this is Robert. I think you're absolutely right that we are moving in that direction. In fact, we see it in our managed care contract negotiations more and more frequently. The whole concept of submitting data directly from their EMR rather than just submitting claims data is frequently on the table. The trick here is an attestation that it's true and a random sampling for accuracy. and giving access to the electronic medical record. And I don't have any problem with that, because that makes my provider's life a lot easier and simpler. And as to your point, it is much more accurate. You know, a blood pressure of 180 over 100 actually measured and captured as discrete data is much more precise than a CPT2 code that's a modifier on an E&M code. So.
And me too. I'm a big believer that the EMR data is going to help predictive modeling in the future, but even right now is very powerful. As Dr. Fortini is saying, that what we want is not necessarily to go after people who have high cost, because what do you do with somebody who is noted to have high cost? What you need to be able to find out is what is actually the drivers of that cost. So, yeah, I mean, somebody that has a blood pressure of 180 over 100, that person's going to have a stroke or a heart attack. That stroke or a heart attack is going to cost $100,000, and you should be able to identify those people and take action on that blood pressure, and you'll prevent cost in the system. And I think the same thing happens with diabetes and people who have multiple comorbidities, people who have multiple drugs, 14 or more drugs. These are all areas in the EMR where you can find these people and do something with them, you know, early, and they will all decrease costs down the road.
Excellent. Well, that takes us past the formal 6 areas of the discussion that we wanted to talk about. We already have a number of questions coming in. I think we're going to allocate about 10 minutes or so for reviewing these questions and getting through as many as we can. And I'll introduce the first one, which was related to the past discussion, which was, how do you see the pharmacist's role expanding within the patient-centered medical neighborhood, and what additional services could be provided by pharmacists to help manage these patients? I guess it goes to your comment about the polypharmacy patients with multiple drugs and medications.
Yeah, I definitely would say that a pharmacist has a distinct role as being part of this team in a patient-centered medical home, and a pharmacist can, in the course of being in the pharmacy, also be able to take on a role. And if you're on 14 medications, I mean, something bad is going to happen, and it just isn't unusual to be on that when you've got 4 or 5 conditions, seeing 4 or 5 doctors. And I think a pharmacist could be interceding either as part of a care team in the office or in the pharmacy in helping to resolve that issue.
This is Robert. I'm employing 3 PharmDs in the medical group right now. They are each scheduled at 1 day a week at each of 5 practices. They see patients on a regular basis. They do medication adherence review. They do med reconciliation for the most at-risk patients. The tool of a PharmD embedded in your practice is something that our clinicians have learned how to use over time. And when you do have a patient who is on 15 or 20 different medications that's struggling with compliance, there's tremendous value of having them sit down one-on-one with a PharmD. The other value I see that pharmacy brings is that as a resource, just in general knowledge around pharmacokinetics and pharmacy management for our clinicians. It's very, very useful to engage them in all of our workflows and discussions around chronic disease management, because they have a unique perspective on the chemistry involved, and they just add another dimension to the conversations. In addition to those 2 items, we have collaborative practice agreements established with each of those PharmDs. So I have them doing annual wellness visits in Medicare, for example. That was one of the Medicare preventative services. So they literally are, you know, practicing up to the fullest level of their licensure and making a big difference.
Excellent. Well, let's go on through another a number of questions that are being submitted. Feel free again to submit questions around healthcare technology or population health technology through the chat or the question area of the GoToWebinar control. The next question has to do with risk tools. There was a question in terms of what are the risk tools that the speakers are recommending or referencing, I should say, and can you provide insight into any of the off-the-shelf predictive analytic programs that are available today?
I'll bring up one interesting reference from the medical literature. For those of you who have pens handy, there's a article that was reported in the Archives of Internal Medicine. It's part of the JAMA family of articles, JAMA Internal Medicine. In the March 25th, 2013 issue, there is a validated survey that was done looking at potentially avoidable 30-day hospital readmissions in medical patients from a consortium of hospitals that will go unnamed in Boston that looked at those markers at the time of discharge that predicted subsequent readmission. The nice thing about this article is that there was also some information on what I talked about before, which is a moving target, which is something we're still working on, and that is impactability. So it's one thing to be able to identify that a patient's at risk for readmission. It's another thing to identify patients at risk for readmission that you can do something about. And I thought this was a nice state-of-the-art article. March 25th, Archives of Internal Medicine. So if you're looking for a reference, there's one.
Excellent. Thank you very much. Well, let's go on to another question. The 10 technologies listed in the paper, there was a couple questions here regarding is it best to build versus buy? And it's a really tough question, and I guess it depends on the size of your facility and the resources you have access to. But does the panel have any suggestions in terms of what to build versus what to buy out of the 10?
Yeah, I kind of have strong feelings about that because I've made something of a journey myself. As someone who really believed in build, that's the world that I grew up in. I must say that I have become increasingly impressed with the ability of outside companies to provide some very adaptable, very user-friendly resources that can really be turnkey implemented into an organization. I have found, what I've generally found is that the decision to buy a particular outside resource is really a function of the local culture and what it is that you need, so there's no right answer here. I would caution that it always seems to turn out to be a mix of three elements: borrow, build, and buy. So you can go to the literature, and there are health risk assessments that are online. ARC has a few of them. You can certainly buy some great predictive analytics from companies, or you may have to hire a few mathematicians and do your in-house predictive modeling or build your own health risk assessment. And I've also found that it's sort of something of a moving target. So the decision that was right this year in 2013 to build, for example, needs to be revisited every once in a while, every 1 to 2 years in 2014 and 2015, where you may need to walk away from something that you put a lot of time into and actually buy or borrow from an outside entity. So the bottom line, it's all of the above, and there's no right answer. It really depends on your local organization, history, and culture.
Guy, this is Robert. I would agree with that, and at Bon Secours, that's our current state. It's a mixed model. We have certain resources that we own. We have certain resources that we buy. And I think we've been pretty successful at using them together. Again, I am also a traditionalist. I think the only way you change human behavior is through relationship building, and that means embedded case management and team-based care and hands-on touching of the patient. So that's difficult to do when you're in a buy-rent situation. But the sophistication and capacity of the resources that are more and more available on the market are improving every day, and we can't ignore that.
Excellent. Okay, with that, I think we're just about at the hour mark and just about out of time. There are a number of questions, and I'll just ask one more question out there regarding the best ways to, once cohorts of patients have been identified as near-term predictive cost or a high expected cost, how does the care team actually best work to engage those patients in the most effective way, and what kind of communications and teaming is done within the care teams to address address certain groups of patients that might need additional follow-up and care.
I'll go ahead, Guy, and give an answer to that. Again, the predictive score helps you to stratify the population, and you'd be able to find the people who are most likely going to go into the hospital, go into the ER, have high cost in the future. Once you identify them, you have to get into the record and find out what it is that's really driving that predictive score. I know from experience that multiple chronic conditions is a big part of it, and when you can identify this and communicate with these patients, you're going to be able to better coordinate care. So that high predictive score is going to hopefully give you those patients that most need a care manager to help pull together the care amongst multiple physicians within the network.
Great. Dr. Sidorov, any parting comments on that?
Not really. I kind of agree with everything Rich said.
Fantastic. And Robert, what are you seeing in terms of Bon Secours?
Well, absolutely. Using the technology effectively is a great starting point. That co-location piece, though, is really valuable. You've got a patient in front of you, and the primary care clinician is across the hall. The communication is broadband and complete. Very, very difficult to replicate in any other modality. That having been said, it's not always possible to have the patient in front of you. And so you got to take advantage of the technology tools for communication.
Excellent. Excellent. Okay, with that, we have a number of questions. We will try to answer those offline. There are just almost too many to be able to go through. But I do want to just spend a minute and just thank not only our panelists, but the organizations they're with, Dr. Hodak, Dr. Sidorov, and Robert Fortini with Bon Secours. You guys have been doing an excellent job in helping us navigate population health and really what the technologies are really required. And I would encourage everyone on the call to be sure to access the PCPCC website and be able to download that the white paper. It goes in a very, very methodical way in terms of what technologies are required for population health, and appreciate everyone's time on the call today. I hope this was useful. It was a little bit different format than we've done in the past. But we felt that this topic really was very widespread and had a number of different elements to it that were worth going through. So again, Dr. Sidorov, thank you so much for your time. Dr. Hodak, Robert Fortini, and the whole Bon Secours organization. Appreciate your all time, and thank you for everyone who joined today. We wish you a really good rest of the day, and feel free to reach out if you have any questions or concerns in the meantime. Have a great day. Thanks so much for joining.